ICS members and guests, good morning. This is a report on intravesical VESIX as a last resort treatment for women with antibiotic recurrent urinary tract infections. I have no disclosures. There are a few options available for intravesical treatment of recurrent urinary tract infections. You obviously know about gentamicin and maybe others like hyaluronic acid. CPC, or cetylpyridinium chloride, was first described in 1939 and commercialized in 1942, also reported in Journal of Urology in 1945 for renal lavage mostly, but also for bladder lavage for bladder infections. It is currently active as an ingredient in lozenges, mouthwashes, nasal sprays. All those are over-the-counter formulations. We used a new formulation which showed ex vivo the ability of VESIX to kill bacteria, mostly UPEX, uropathogenic E. coli, isolated from patients. All were killed within 15 minutes at different concentration and regardless of urine pH. We present here a brief experience on 3 women, all candidates for cystectomy and urinary diversion as their last resort options. This was a both FDA and RUTI-approved trial at our institution. Here's a brief description of one typical patient of the 3, 77-year-old female, lifelong history of urinary tract infections, pyelonephritis as a child, on average 6 courses of antibiotics a year, E. coli mostly identified in the urine, allergies to 27 drugs, including several classes of antibiotics as listed here, has had 3 treatments for C. difficile, has failed all oral antibiotics, including fosfomycin, which she took every 10 days for several years, intravesical gentamicin. She has been hospitalized multiple times for urosepsis, pyelonephritis, and has been on countless rounds of IV antibiotics. She's only sensitive now to 2 antibiotic classes, gentamicin and the penams. She has some incontinence, she has normal upper tracts, chronic cystitis, and cystoscopy. Here's a protocol that we use in this FDA-approved study. The patient had to be symptomatic and first treated with an antibiotics. During that antibiotic treatment, VESIX was tested ex vivo, and if shown to be efficient, again, the bacteria was allowed to be placed in the bladder. The placement was done through a Foley catheter. On the day of the installation, the patient was asymptomatic with a negative urine analysis. VESIX was instilled slowly under gravity. The catheter was clamped for 15 minutes. Urine was collected before and after VESIX. The catheter was then removed, and the patient was monitored for 2 hours for possible side effects according to the FDA protocol. Then they were followed weekly and then monthly up to 6 months. The urine that was collected before and after VESIX was sent to the lab at Nisco for bacterial identification and bactericidal assays. Bacteria present in the urine were noted before the VESIX and after the VESIX. All the cultures were negative. The pathogens that were identified were both gram-positive and gram-negatives. And on bacterial assay, no growth was observed in the VESIX-treated samples that correspond to the red dots at the bottom. So these results from our lab show that clearly VESIX is bactericidal. All bacteria isolated from the urine of these 3 women prior to VESIX treatment were all killed by VESIX, normally ex vivo, before the VESIX was given, but also on the day of the treatment. And VESIX was effective against gram-negative like E. coli and gram-positive like E. faecalis uropathogens. So VESIX is clearly advantageous. It can be tested ex vivo prior to being placed in the patient's bladder. This is a very limited trial with very limited experience. Briefly, how did this patient did a year later? One is still completely cured, which is quite impressive after 1 treatment. The second one had durable improvement with only a few infections during the year, with a E. coli much easier to treat, much less resistance, so much better bacterial profile in antibiotic choices. The third patient failed and has still preserved the bladder, but is definitely under cystectomy consideration. So going forward, we hope to be able to extend that experience to more patients to further define the role of VESIX in our armamentarium. Thank you for your attention. I welcome all your questions.